Good afternoon, everybody. Thanks for having me on, Joe. It's a pleasure to be back talking about a pretty common scenario, pain in people with addiction, so chronic pain and addiction. I always start with my disclosures. I really don't have any huge disclosures to make. Oh, I'm struggling to advance. Sorry, Joe. Hold on. Yeah, here we go. So I don't have any material disclosures to make. These are all my income sources. If I'm off-label, meaning I'm talking about unapproved or investigational uses of medications, I'll tell you. This would come up, for example, during the question and answer segment. All right, what do I endeavor to do over the next 45 minutes or so? I'd like to talk about what is known about opioids for chronic pain. There's been a lot of changes in the way we've thought about this over the past few decades, and the pendulum is swinging decidedly in another direction. What we know about opioids for opioid addiction, I think the evidence is pretty well settled there, but I'd like to get into it. And then we're sort of stuck with what I call a clinical conundrum. What do you do with somebody who has opioid addiction but also has chronic pain? And then finally, I'm going to get into assessment because that's absolutely key. You really need to establish, in my opinion, whether or not somebody has addiction. So chronic pain patients, you need to establish or rule out whether they have addiction because that has big time treatment implications for what is most appropriate for them. Let's dive into opioids for chronic pain. So again, the thinking on this has changed a lot over the decades, even in my relatively short practice lifetime. I've been practicing since 2001, and even in my practice lifetime, a lot has changed. Prior to the 1990s, late 1990s to be specific, really the only way that you would be offered an opioid was a couple scenarios. One was acute pain. So if you had an illness that caused pain, if you had an injury like a fractured bone that caused pain, or if you had acute pain due to a surgery, that would be an appropriate circumstance for the use of an opioid. The other circumstance that was felt to be appropriate for the use of an opioid was cancer-related pain, especially end-of-life type pain. So those are the basic premises. That's how you could receive an opioid for pain prior to the late 1990s. In the mid to late 1990s, this all changed. And so there was an open question posed, like there's a lot of people with chronic pain that's not cancer related, it's not acute pain in nature. Would it be okay to treat them with opioids for chronic pain? And the leading lights at that time, the American Pain Society and another pain society, the American Academy of Pain Medicine, they came up with a practice guideline that completely changed the way we thought about the use of opioids for chronic pain. And they basically said it'd be okay. And so the practice guideline issued in 1997 jointly by those two organizations said, the undertreatment of pain in today's society is not justified. We are issuing a joint statement pursuant to the missions of both organizations to help foster an environment in which opioids may be used appropriately to reduce needless suffering from pain. And then they stated it is imperative that the statement not be misconstrued as advocating the imprudent use of opioids. Now the problem is it did become actually one of the reasons why opioids started to become imprudently used. The other factors, there's three factors in this perfect storm. One was this practice guideline where the Pain Society said, you know what, it's possibly okay to use opioids for chronic pain. The other two factors were the Joint Commission, which accredits hospitals, stated appropriately that pain was being undermanaged in hospitals. And that got completely misused. It's true, and it's probably still true, that acute pain following surgeries is undermanaged in hospitals, but this whole idea that pain is a fifth vital sign, that we need to ask patients about it incessantly, and then provide opioids became an issue. And then the third feature of the perfect storm was long-acting opioids. Purdue Pharma produced extended release or controlled release oxycodone, known as OxyContin, branded OxyContin. So this statement plus the Joint Commission focusing on pain and OxyContin became available, created the perfect storm in the late 1990s that promoted the opioid epidemic that we're still dealing with. When dealing with patients with chronic pain, there's really two issues on the table. One is analgesia, pain relief. Pain is a noxious, uncomfortable sensation, and so patients want to get rid of that. The other thing, though, is function. Can you improve pain-related function? So a lot of people with chronic pain aren't fully functional. And so when you're treating them for chronic pain, you want to maximize function, you want to restore function. And so those are the two issues that physicians deal with when dealing with chronic pain. Now here we are literally 20 years later. So in 2017, after the opioid epidemic completely created problems for our society, the Pain Society sort of walked it back, and they published this massive clinical practice guideline with like 700 plus references. And now they're focusing on the safe, responsible, and effective prescription of opioids for chronic non-cancer pain. And so this is a practice guideline. And it's sobering, really, to sort of go through. And I'm going to give you a really high-level look at a couple sections. And so this is a 90-page document. 715 references went into the preparation of this clinical practice guideline. And two sections, I think, merit our attention today. One is whether or not opioids are effective for chronic pain. And one of the sub-questions was key question number 4. What is the evidence for the therapeutic efficacy of opioids in managing chronic non-cancer pain? So what do the studies say? Another section, what are the adverse consequences of opioid therapy? The key question in that section is, what are the adverse consequences and harms associated with chronic opioid therapy? So I'm just going to walk you through really the high-level findings from those sections. So here's the Twitter summaries. If you're into counting characters, I'm pretty sure they're all under 200, whatever. So none of the studies, so they looked at the world's literature, literally. They did a systematic review. They looked high and low for everything they could find on the subject of opioids for chronic pain that isn't due to cancer. And they basically said, of the studies we found, none of them evaluated the long-term benefits for over a year. So we have no data, really, no studies really commenting on whether these are effective in people taking them long-term. The evidence on long-term efficacy is therefore lacking. There is no evidence that opioids improve return to work or reduce the use of other treatments. So again, the slide prior, I talked about pain relief and functions. So there's no evidence on improved function, return to work. Ironically, opioids may limit the effectiveness of other treatments, so non-opioid treatments. Few studies, few trials compared opioids to Advil. So NSAIDs include ibuprofen, which is Advil, naproxen, which is Aleve, so, or antidepressants. Common antidepressants used for chronic pain would be something like Cymbalta, which is duloxetine. So there weren't a whole lot of studies that compared opioids to NSAIDs and antidepressants, but of those who did, studies that made those comparisons, there was no difference. So opioids, NSAIDs, antidepressants, same pain, same function at the end of the studies. Insufficient evidence for assessing long-acting opioids. So this would be like the oxycodone controlled release, the OxyContins of the world, morphine, sustained release, MS-Contins of the world. No evidence, insufficient evidence really on whether those are effective for chronic pain. We were not able to find any studies on opioid therapy versus no opioid therapy for long-term outcomes at a year, pain, function, quality of life, opioid abuse or addiction, which when you think about it is mind-blowing. I mean, the number of prescriptions that have been issued for chronic pain, really with a very tenuous evidence base, not much to commend it. No intervention per se produced clinically important improvement in average pain intensity. No convincing unbiased evidence suggesting that oxycodone, long-acting, so OxyContin, is of value. So there you go. Purdue introduced OxyContin in the 1990s. It was widely prescribed. Really no convincing unbiased evidence that it's helpful. Again, no clear difference in studies between ibuprofen, naproxen, long-acting opioids, short-acting opioids. So really ibuprofen probably equivalent to opioids is what this is saying. The clinical significance of the results is uncertain due to the modest difference between efficacy, high heterogeneity, et cetera, et cetera. What they're basically saying here is the quality of the evidence is really poor. The study quality is poor. There was big time limits in study design and how you can interpret it. So even of the available studies are flawed in many ways, that leads us to believe the results are uncertain. And then there's significant bias. A lot of the studies that have been published were subject to various bias. They were too small in size, not enough patients involved, not long enough in duration to be meaningful in the real world. People who dropped out of the studies weren't accounted for adequately. So again, what they're saying is, of the studies that are available, lots of methodological flaws prevent us from using them in meaningful ways. Again, little or no evidence on the effectiveness of opioids in the treatment of chronic pain in the frail elderly, so specifically looking at that patient population. No studies on the effectiveness of opioids for people with HIV-related pain. And in terms of opioids for chronic pain, those who took opioids for chronic pain reported, ironically, more severe pain, poor self-related health, they had more unemployment, they used healthcare more, and they said that their quality of life is lower compared to those who did not receive opioids. So again, this is not looking like a really terribly good intervention. And then finally, liberal prescribing of opioids for chronic pain in the studies presented, people had worse pain, increased healthcare utilization, reduced activity levels. So again, from a pain standpoint, functional standpoint, people not doing better on opioids compared to non-opioid therapy. Getting to function again, increased functional disability in people with chronic pain who receive long-term opioid treatment, reduced function after therapy received, higher pain intensity in those receiving opioids, greater disability in those receiving opioids, more depression in those receiving opioids compared to those who did not receive opioids. Long-term disability is associated with those who received opioids. Patients who received opioids had worse pain functioning. They had more catastrophic thinking about movement and depression. Lack of improvement in disability in those receiving opioids for chronic pain. Those who received opioid therapy for chronic pain had higher disability compared to those who did not. So, I mean, this should, I think, depress us all. So in the 1990s, these were being marketed aggressively to patients, consumers, as being helpful. And really, we don't have any evidence. There's lack of evidence that opioids are helpful for chronic pain. Or of the studies that are available comparing opioids to no opioid therapy, there's no benefit compared to no opioids, or there's no benefit compared to ibuprofen that you could buy on your own at Walgreens. Or the opioids are frankly harmful. And so again, super sobering. Here we are 20 years in, and it's been a disaster. We just don't have any evidence that this is something that we should be doing for patients. Let's move on to the next section of this evidence report. Are opioids harmful? Well, hopefully you know the answer to that, but I'll get into it. These, again, are direct statements from that clinical practice guideline. Fatigue, problems thinking, dry mouth, sweating, weight gain are frequent side effects. And these side effects are reported to be eightfold higher than those reported voluntarily. So if you ask a patient straight up, hey, are you having any side effects due to your opioids? They may report something, but they're likely to underreport. But when you make a patient fill out a checklist saying, hey, are you having fatigue? Are you having problems thinking? Do you struggle with dry mouth and sweating? When you actually force patients to answer questions like that, they will say, yeah, I'm having that. And the rate of reporting on that is eightfold higher compared to voluntary reports. About 80% of patients who take opioids experience at least one adverse event: constipation, nausea, and somnolence, sedation being probably the most common one. So these are certainly not benign medications. Opioid associated endocrinopathy, so that's just a fancy way of saying it messes up with your hormones. So opioids will influence the way that your pituitary gland communicates with the rest of the glands in your body. And a common one is androgen deficiency. I see this all the time in men. So men with low testosterone, which causes problems with mood, energy, sexual problems. So opioids can cause that problem in men as well as women, but especially men. And perversely, opioid-induced hyperalgesia is super common. This is basically when you are exposed to opioids, your body's not stupid and it upregulates your pain sensing apparatus, and you're more sensitive to pain when you take opioids. And so patients who take opioids chronically, they will rate pain due to, say, surgery as much more painful than those who do not take opioids. So opioid-induced hyperalgesia is a common phenomenon. And of course, probably nobody on this webinar will be surprised. Opioid-related deaths from overdoses is a common issue. Hospitalizations for opioid poisonings among children and adolescents. These might be intentional, for example, children getting into their parents' pill bottles, adolescents maybe experimenting with opioids that are available to them. With the multitude of issues described, it's disturbing to know, and you see this all the time, more than 90% of patients who survive an overdose go back on opioids. The provider who is prescribing the opioids just refills them. And this is always disturbing. I certainly see this. I've seen cases where a patient literally walked across the parking lot after being discharged from the hospital into their primary care clinic after an overdose and renewed their opioid prescription. So the summary in this section is various harms exist with opioid therapy. They're likely underestimated or they're underrecognized by clinicians. So really the literature does not shape up well. So opioids not effective for chronic pain and are harmful in various ways. So this should be kind of a no-brainer. So the whole sea change that's occurred in my practice lifetime, I entered medicine in the early 2000s. So prior to the 1990s, don't use opioids for chronic pain. That all changed in the 90s. Now we're sort of back to where we were in the 90s. Don't use opioids for chronic pain, and there's a reasonably good evidence base for that. All right, how about opioids for opioid addiction? Using opioids to treat those who are addicted to opioids. I've made a career out of understanding this literature and treating people for opioid addiction, and this is where, you know, opioids are probably a good idea. And so we've always known that opioid addiction is a bad illness. So the first opioid epidemic actually occurred in the 1800s. When you look at when opioids became available, Bayer, the corporation that brings us aspirin, identified what in poppy seeds, or the poppy plant rather, led to pain relief. And in the early 1800s, they identified that chemical, they called it morphine, and they brought it to market. And after morphine came to market, it became the first opioid epidemic. So here we are, Journal of the American Medical Association from 1890. And doctors are talking about the treatment of the morphine habit, opioid addiction. 1912, Journal of the American Medical Association, so over 100 years ago, morphinism and its treatment. And this is the next slide is a segment out of this article from over 100 years ago. Nearly every physician has made an effort to rescue from the addiction, meaning opioid addiction, its victim. And as a rule, has given over the effort as hopeless, because even when the patient is taken off his drug, he relapses to opioid use. So we've all sort of known that opioid addiction is a bad illness. This was known for well over 100 years. And really that position has only been reinforced by studies since then. I have entire slide decks. You've possibly sat through some of these slide decks. I've been presenting them for years, showing what is called the natural history of opioid addiction. So here's the natural history of addiction in general, but opioid addiction in specific. I could show you literally an hour's worth of study that show you the same thing. So this study is a pretty straightforward one. At time 0 on the x-axis, people were discharged from addiction treatment. So everybody received addiction treatment right here. At time 0, everybody is drug-free. So 100% of people are free at discharge from addiction treatment. And the question becomes, how many remain drug-free over the next year? So here's the run out over 1 year. How many people remain drug-free at 1 year? And this is just the way addiction behaves. So even with addiction treatment, people return to substance use. And when you look at the opioid line, which is the red line, people use opioids following addiction treatment. So at the 1 year mark, you know, the majority of people are using opioids again. You know, something like 60% of people at 1 year are using opioids again, but they're also using cocaine, alcohol, and marijuana. I mean, this is what happens even when people receive addiction treatment. Substance use is a common thing. Now, we really had no credible treatments for opioid addiction until this landmark paper appeared. So this appeared in the Journal of the American Medical Association in 1965. It was a husband-wife team, Vincent Dole and his wife, Marie Nieswander. They were physicians practicing at Rockefeller University in New York. And they started to look at treatments for opioid addiction. And they specifically zeroed in on heroin addiction. And this paper described the first successful treatment of people for heroin addiction with methadone. And so in 1965, we finally had credible scientific evidence that there was a treatment for opioid addiction. Now, it was really difficult to get methadone actually to patients. We tried to criminalize opioid addiction out of existence. So when methadone became available in 1965, we had a wedge methadone into all the laws that preceded it, including the Pure Food and Drug Act in 1902, which led to the formation of the Food and Drug Administration. There was the Harrison's Narcotic Act. There was all these laws that made it illegal for doctors to treat opioid addiction with opioids. So when methadone became available, we had to create a special treatment infrastructure. And I think everybody commonly knows it as methadone clinics. So methadone clinics are life-saving, but they're not widely available. They're subject to a lot of laws. And the laws, originated well over a century ago in many cases. Now, the question becomes, and I'm still dealing with this surprisingly in 2020, is methadone an effective treatment for opioid addiction? Is Suboxone, also known as buprenorphine, an effective treatment for opioid addiction? We have piles of literature on this, but in Minnesota, we've struggled with this. It's a cultural thing in Minnesota. Are these medications effective for addiction? The answer is an overwhelming yes. So this is a review article published in 2010. 38 studies were found that looked at quality of life. People taking methadone or buprenorphine for opioid addiction, what's their quality of life like? Here's sort of the high-level summary. So based on those 38 studies, participation in substitution treatment, so methadone or buprenorphine, had a positive effect on health-related quality of life. Improvement in various life domains was obvious early on, so first months of treatment. And this is consistent with my experience for sure. Getting people on these medications leads to a very dramatic improvement in their clinical status. And then more importantly, the observed improvements persist over a long-term period of time. So again, 1965, we finally have a study that demonstrates methadone's effective. We have a ton of studies that follow. We got a bunch of studies in buprenorphine, which is Suboxone. It's a good idea. In fact, yesterday I circulated an article that just appeared in the Journal of the American Medical Association. It's the latest one, and it's certainly consistent with all prior studies. It was a study that looked at methadone and buprenorphine versus other forms of treatment for opioid addiction, including antagonist therapy, which is naltrexone. Also looked at residential treatment, intensive outpatient treatment. So it made a number of comparisons. Very consistent with prior studies. The only treatments that were effective were methadone and buprenorphine. There was no evidence of effectiveness for those other interventions. Now, in Minnesota, at least, there's always this pressure to taper off. We finally have conceded. I mean, this was kind of a big uphill climb early in my practice career. So again, I've been doing addiction since the early 2000s. So the battle that was being waged in the early 2000s was to get methadone and buprenorphine to people. In Minnesota, I think we finally have accepted that that's an okay thing, but there's still this pressure to taper off. So it's like, well, I'm glad that you were able to stabilize the patient on Suboxone, but when are you going to get them off that Suboxone? The evidence on this is pretty compelling. Those with opioid addiction do really poorly when they come off of opioids, including Suboxone. And this has been studied to death. We literally have a century of literature that shows that people who come off of methadone and buprenorphine have a very high rate of relapse and a lot of incredibly negative consequences, including excess rates of death. So again, we have piles of literature. This is a review article from 2001. I love the title on this one, Leaving Methadone, Lessons Learned, Forgotten and Ignored. So here we are in 2001, they already had over 30 studies that looked at what happened to people when they discontinued methadone. Very high level. Most patients who left methadone were not identified as therapeutically ready for discharge by their treating clinic or providers. Of patients who began a therapeutically planned discharge, most left treatment before completing detoxification because they relapsed. And then finally, of those who completed the entire taper as planned, most relapsed to heroin use. So these studies, were from before 2001, and we already had 30 of them that said, hey, this is a really bad idea. People with opioid addiction, stable on methadone, it's a really bad idea to take them off their methadone. And the evidence base has only gotten stronger since then. So this is a really big, bad systematic review that was published in British Medical Journal in 2017. It's an update actually of one that was published in the same journal a few years prior. And the study was pretty straightforward. They looked at those who were taking methadone. They looked at those who were taking buprenorphine. As you can see, there was a ton of people pooled into the study. There was over, 100. There was basically 123,000 methadone patients that were pooled. There were 16,000 buprenorphine patients. And the question became, what was the rate of death while they were taking methadone or buprenorphine? And then more importantly, what was the rate of death after they stopped taking methadone or buprenorphine? And so you can see that the rate of death goes up when people stop taking these life-saving medications. And fatal overdoses likewise went up when people stopped taking these medications. So again, this is pretty settled science. It's crazy that we're still debating this to some degree in Minnesota. There is a mountain of evidence that these are effective medications that meaningfully change people's quality of life, and that when they stop taking these medications, they do poorly. This is totally, by the way, like every other chronic disease. Heart failure patients do better when they take their heart failure medications compared to when they stop. People with psoriasis, the skin problem, they do better when they're taking their psoriasis medications compared to when they stop. Pretty much any chronic disease is you're going to do better with disease modifying therapy. You're going to do very poorly when you stop taking disease modifying therapy. All right, so here we are. We got evidence that points in two different directions. So let's talk about pain. The evidence is very clear that if you have chronic pain, taking opioids for chronic pain, it's a big, bad no. It's probably a really bad idea. On the other hand, if you have opioid addiction, taking an opioid chronically for opioid addiction is a resounding yes. The evidence points strongly in that direction. The question becomes, what do you do with this overlap? So I think all of us who specialize in addiction deal with this wedge in the middle. So if you have chronic pain and you also have opioid addiction, what should you do? I will tell you there's not a great evidence-based answer. I have looked at this literature for years. There's not a great evidence-based answer. And so I'm going to give you a probably just based on expert opinion. And I'm going to try to explain why that is. The reason is you're probably not going to do any better from a chronic pain standpoint if you take medication, an opioid medication, but you're going to do much better from an addiction standpoint. So the discussion I have with patients is, look, here's a scoop. You have opioid addiction. This is a really bad chronic illness. You're going to do well, if not great, if you take a medication like buprenorphine or methadone for addiction. It may not do anything for your chronic pain syndrome. If you get a little bit of benefit from a chronic pain standpoint, that's bonus. But I'm trying to keep you alive, and I'm trying to improve your quality of life. So that's kind of my reasoning in offering patients buprenorphine and methadone for addiction. But I'm really clear as to what to expect. My intention in giving you these medications, prescribing these medications, is to target your addiction. If you get some bonus for pain, that's great. So this really brings us to a really fundamental issue is, does the patient have addiction? And this is where I'm sort of the Abe Lincoln of addiction medicine. This is kind of an old saw. We don't know if Abe ever said it, but it's often attributed to him. So a woodsman was once asked, what would you do if you had just 5 minutes to chop down a tree? And Abe Lincoln apparently stated, well, I would spend the first 2.5 minutes sharpening my axe. So it's the same sort of deal with addiction. So, hey, friends, if I give you 90 minutes for a diagnostic assessment, how are you going to spend your time? Well, I'm going to spend 85 minutes really trying to nail down whether they have addiction. I'm going to spend the majority of the encounter on that question because I have to figure out which one of these bubbles they're in. If they have pain, no addiction, the answer is clear. If they have addiction, no pain, the answer is clear. If they have addiction and chronic pain, then we're probably down here. So I really need to sort out this slide, and I'm going to spend a ton of time doing it. So how do you assess patients for addiction? This is surprisingly harder than it seems, even for a skilled clinician, because not every patient is willing to self-disclose. And so as everybody well knows, the diagnostic standard comes from DSM-5. And so opioid use disorder is defined by DSM-5 as the name of the game. So DSM-5 states that opioid addiction is a problematic pattern of opioid use leading to distress or impairment. You have to fulfill at least 2 criteria over a 12-month period. So this is the lens by which we look at the patient. And everybody well knows the 11 criteria: larger, longer, unsuccessful efforts to cut down or control, great deal of time spent on opioid use, cravings for opioids, trouble fulfilling role obligations due to opioid use, continued opioid use despite social or interpersonal problems, Opioids interfere with important activities, socially, occupationally, recreationally. Using opioids in physically hazardous situations. Continuing to use opioids despite the knowledge that they're harmful. And then tolerance and withdrawal. Now, these are really straightforward for the patient who wants to self-disclose. And so, you know, the patient who walks through my door and they admit they have a problem with opioids, this is super straightforward. It's not a diagnostic challenge at all. Where I think it gets diagnostically challenging is the patient perhaps with chronic pain who does not want to sacrifice their opioids for chronic pain. They may not be willing to self-disclose any of this stuff because it'll jeopardize the medications which they value. In terms of the approach to diagnosis, I'm a big fan of structured clinical interviewing. Some of you may have actually taken my classes. I used to teach structured clinical interviewing classes at the University of Minnesota for the Addiction Studies program. So DSM has companion instruments called SCID, so DSM-5, SCID materials. SCID-5CV is major depressive disorder, generalized anxiety disorder, stuff like that. There's also a SCID-5PD, which is for personality disorders. So these are structured instruments that allow you to interview people. And this is the way they go down. They're basically an interview script, and I'm going to zero in on an item here. And so the gray part of the SCID interview script is the DSM-5 criteria verbatim. So this is a reproduction of DSM-5. And then what you do is you're interviewing the patient. Have you found that once you started using heroin, you ended up using more than you intended to? And if they say yes, you want to get a sense for what happened. Well, tell me about that. How often did it happen? What you're trying to do is form an opinion as to whether this criterion has been fulfilled. If that criterion has been fulfilled, you circle this and you move on to the next question in the SCID book. And so it's a bunch of questions like that. You're just basically marching through all 11 criteria in the opioid use disorder criteria set, and you're determining whether or not they fulfill individual criteria. And at the end of the day, if they fulfill 2 or more criteria, they meet criteria for the illness. Now, again, this is very straightforward in the patient who's willing to self-disclose. For the patient who is not willing to answer questions that are super face valid, you're going to struggle. By face valid, I mean the patient has absolutely, there's absolutely no doubt what you're fishing for. These are all pathological questions. A patient who wants to conceal or fake what's going on, they know what you're fishing for, and it's going to be easy for them to lie to you. So this sort of gets into the realm of what do you do next? For the patient who is not self-disclosing and you're worried they may not be self-disclosing, what do you do next? Well, in a perfect world, collateral is helpful if you can get reliable collateral. It's often not available. They're not willing to sign releases, or the collateral that they make available to you isn't helpful. Maybe their collateral sources are colluding with them. So psychological testing comes into play. I do a lot of testing in my practice. I administer at least 3 tests, sometimes more on the front end. So every patient I see for a brand new interview, a diagnostic interview, it's going to be a 90-minute interview. It's a 2-hour appointment, to be honest. So 2 hours, they fill out paperwork for about a half hour, and then it's a diagnostic interview for 90 minutes of it. And then I'm going to administer a bunch of tests. For sure, I'm going to administer this one, substance abuse settled screening inventory. I may administer other ones. I typically will administer the brief symptom inventory, the BSI, as one of my things on the front end, and then the Paulus deception scales, the PDS. So I will administer a SASI-4, a BSI, and a PDS to everybody on the front, and then I may layer in additional psychological tests. So the SASI-4, the substance abuse settled screening inventory, it's about 100 questions, and they're distributed across 3 scales. There's a bunch of alcohol questions, other drug questions, and there's other scale questions. And what's baked into the questions are a bunch of response style questions. What you want to get at is whether or not the patient's a truthful respondent, whether or not they're answering questions truthfully. So there's a lot of questions that have nothing to do with substance abuse that are baked into this test. And it's got pretty good sensitivity and specificity. but it's not completely perfect, but it allows you to get a sense for whether or not somebody is a forthcoming historian. There's an entire psychological literature on this. MMPI does have a substance abuse scale. It's the subscale. There's 7 items in that particular subscale. And you know, the MMPI doesn't have a cut score. They look at the correlation with some sort of gold standard. It's correlated with addiction, but it's not perfectly correlated. I mean, maybe half the time there's a correlation between how they respond to the MMPI and addiction. So it's an okay test, but it's not I'll tell you, it's not a great test for addiction. So people put a lot of confidence in the MMPI, its ability to detect faking and deception. I would say for addiction, not great in its ability to find faking and deception. The Milan, the MCMI, I like it. I administer it way more than MMPI, but I typically do not administer it to find addiction. There are 2 scales in the Milan. The B scale and the T scale. One has to do with alcohol, the other one has to do with drugs. It's 12 questions in total. And you know, sensitivity and specificity are probably okay, probably superior to the MMPI, but I'm going to point out there's issues with this. So I don't administer this necessarily to find out whether somebody has addiction. It's helpful, but I use other scales. And this is a big, bad, over 200 item. It's 212 items. BHI2, I just administered it the other day. It is 200 items for chronic pain patients, and there is one scale that has to do with substance abuse in it. So of the 200 items, there's 7 questions that have to do with substance abuse. Correlation with true addiction is not great. So at best, about half the time, there's a correlation between how they respond to these questions and the presence of addiction. So again, it's available. It's not a great test. I administer it not to find addiction. I administer it to find out how people think about pain, their functional limitations associated with pain. There's a lot of other reasons I administer this test, but I have low confidence in its ability to find addiction. So I think a lot about malingering and deception, probably a lot more than the average physician. There's pretty good reason for that. I'm the medical director for a couple jails up in central Minnesota. So I'm the medical director for the Stearns County Jail, which is in downtown St. Cloud, and the Benton County Jail, which is in Foley, Minnesota. That's another one of the St. Cloud counties. And so you have to think a lot about this in jail. And so this is a textbook. It's been through 4 editions. And it's the state of the art on how to detect people who are faking, malingering, and trying to deceive. And there's a chapter on substance abuse, like how do you detect people who are trying to fake like they don't have substance abuse. And it's kind of depressing. So MPI, which has been around since the 40s, that scale that I pointed out, is remarkably susceptible to faking. And in naturalistic and simulation studies where you pay college kids to fake illness or fake wellness, so it's remarkably susceptible to manipulation. And so we need a lot more work in our use of that particular scale. MCMI, the Milan, again, it appears vulnerable to faking. And so there's really no published literature on its ability to detect denied or exaggerated substance abuse. So again, for patients who are motivated to disclose, no issue. For patients who may have incentives to not disclose, you're going to struggle. You're going to need collateral if it's available. You can administer tests. The tests have their problems. All right, so how about patients with chronic pain who receive opioids for chronic pain? There are some criteria, Portnoy's criteria have been available for a long time. And so this is a set of criteria. I'm going to show them to you on the subsequent slide that give you a sense for whether or not addiction might be present. They're reasonably sensitive and specific. So here's Portnoy's criteria. You know, addiction basically as consistent with DSM-5. Evidence of compulsive drug use. Again, this is kind of consistent with DSM-5. Where this gets different than DSM-5 is the stuff down here. So are there behaviors that are suggestive of addiction? And so basically Portnoy's criteria, you can apply these and find whether or not there is probable addiction. So this is a yes, no, this is a yes, no, and then one or more of the following. You know, so if you have basically all three of these fulfilled, you probably have addiction. So this is helpful because a lot of times it's not clear, or if you apply the DSM-5 criteria, it's not clear whether they have addiction. This takes a much broader view of addiction. And then finally, there's something called the Addiction Behaviors Checklist. This is a very brief instrument that can be used during chronic pain visits. And it's 20-ish items. They're yes or no items. So have there been addiction behaviors since the last visit? So illicit drug use, problem drinking, medication hoarding, overusing, running out, self-escalating, stuff like that. So it's a checklist, yes or no checklist. And what's nice is, there's a sensitivity and specificity again. So 3 yeses or more is worrisome. And so again, if you're treating patients for chronic pain and they're on opioids for chronic pain, this would be something you could mix into those visits to assess for the possibility of addiction. Now I'm going to point out there's every healthcare system. I work in a couple of them. I work for Alina as well as Centricare up in St. Cloud. Every healthcare system has tens of thousands, I'm not exaggerating, patients on opioids for chronic pain, and probably they're not coming off. It's really hard to get people off opioids. So a checklist like this can be very helpful in supervising chronic pain visits. All right, let's run through some conclusions here, and then I'll take any questions that you may have posed. So patients with chronic pain syndromes and opioid addictions are probably best served by opioid agonist therapy. And by that, I mean Suboxone or methadone. Why do I believe that? There's a lot of evidence that people with opioid addiction have better outcomes when they take those medications. I never overpromise on this. If they get a little bit of benefit in terms of their chronic pain syndrome, that's great. But really, my intent in treating people with methadone or buprenorphine is to improve addiction outcomes. Addiction is a clinical diagnosis, and really the only way to do it is a careful interview. I would say SCID 5 is super helpful. I love structured clinical interviews. If you can pull in collateral data, that's great. Psychological testing can be useful. That's sort of the key word, can be useful, but it's vulnerable to faking. Dissimulation is sort of the fancy word for faking. And here's where I hang out some of the time. I'm on the 14th floor looking at Fauché. The sun has been coming in my window lately in the mornings. It's awesome. And with that, I will entertain any questions that the audience may have.
Thank you, David. We have one question so far from Caitlin, who asks, what do you mean by a cultural struggle regarding methadone clinics?
Yeah, so super good question. So the Minnesota model for opioid or for addiction treatment began in Minnesota. And so Minnesota is famous for it. And when you sort of look at the history of the Minnesota model, it was rooted in the treatment initially of those for alcohol use disorder, alcoholism, alcohol addiction, however you want to describe it. And it's an abstinence-based model. And so the Minnesota model was you need to abstain completely from alcohol. I'm okay with that. The problem is the Minnesota model doesn't work for opioid use disorder. And so the Minnesota model has been applied to other substances. And the abstinence-based treatment to opioid use disorder, I think, is disastrous. So when you tell patients, you know what, you got to be off opioids, you can't take opioids, you need to abstain from opioids. That has been the thinking in Minnesota for decades. The Minnesota model, came to be in the 1940s, 1950s, and the Minnesota model really was the way we thought about addiction. And so for years, even early in my practice lifetime, patients were told methadone is bad for you, you shouldn't take it, or if you do start taking it for addiction, you better get off. And the science just doesn't support that. There's really no evidence that abstinence-based treatments are effective, and more importantly, there's evidence that they're harmful.
Can you hear me?
I can hear you, Joe.
Okay, perfect. Joyce asks, what are your thoughts on Vivitrol, the injectable naltrexone that lasts for 28 days?
High level, it's a okay, if not good treatment for alcohol use disorder. I don't think it's a great treatment for opioid use disorder. I think you can make a case for narrow use of Vivitrol in certain patient populations, but probably methadone and buprenorphine are going to be better choices for a variety of reasons. And I'll tell you why. From a cost standpoint, methadone and buprenorphine far cheaper than Vivitrol, the injectable. From a patient compliance standpoint, patients really struggle. It's a large, painful injection, and patients just don't stick with it. And then just from a scientific standpoint, I think we have a lot more evidence that methadone and buprenorphine are effective. It's really kind of iffy. We finally do have a couple studies that say that Vivitrol may be equivalent to Suboxone, but there's tons of caveats with those studies. And then more importantly, the JAMA study that just appeared yesterday, the one that I referenced at the top of the hour, found that it wasn't effective. The only effective treatments in that particular study were methadone and buprenorphine. So okay for alcohol use disorder, although I think most of the time oral naltrexone is going to be just fine. And probably for opioid use disorder, maybe people leaving jails, maybe people leaving prisons, maybe patients with big time compliance issues, and the injectable is a safer choice. But most patients who can take medications, methadone and buprenorphine are going to be more effective and better choices. Other questions, Joe?
Thank you. Amy asks, how long would a patient be on Suboxone or methadone? I had an addict tell me that Suboxone was, quote, harder to get off than heroin.
So great question. I don't have a time frame. That's like asking, you know, when will we stop a diabetic's insulin, or when will we stop their lithium for bipolar, or when will we stop their diuretic for heart failure? Really, the patient gets to decide. My job is to tell them what illness they have. So you have opioid use disorder. My job is to tell them the available treatment options, including no treatment, the benefits of the various treatments, the risks and harms of the various treatments, and then they get to decide what they want to do based on their values and preferences. With that said, I've been doing this a long time. Most patients, when you have that informed consent discussion, they're not interested in stopping Suboxone. It just doesn't make sense to most patients to stop it. In terms of discontinuing Suboxone, I suppose, I mean, it can be difficult to taper off of any opioid. But again, I think that's a really clinically dangerous posture to take. I seldom do it. I mean, if a patient wanted to do it, I'm going to have a really frank, informed consent discussion and say, look, the studies would say your risk of overdose, your risk of death goes way up. If you're willing to embrace that, we can try, but you have to be willing to embrace that risk. Most patients, honestly, they say, you know what, my life was a disaster before I started taking Suboxone, and now my life is great. Why would I want to risk everything I've gained? So there's a lot of nuance to that question.
Sure, understandable. Thank you. Marilyn asks, so if you can't access methadone or Suboxone therapies, what hope is there for someone with chronic severe pain?
Well, there's non-opioid options, and they're probably underutilized. You know, the last 2 decades we've been sort of stuck in the opioid mindset, and so I think we need to make options more available. I'll give you some examples. So, you know, a lot of people have chronic back pain. We have some great interventional options like radiofrequency ablations. We have non-opioid medications, including stuff like ketamine. And so I think, you know, we're not offering patients everything that can be offered, is my point.
Okay, thank you. Caitlin says, you covered the benefits of MAT well. Thank you. Are there any long-term negative side effects that have been proven?
Yeah, and I'm super blunt with patients. Medicines are poisons. They interfere with the way your body is designed to work. So I never short sell that, regardless of what I'm prescribing. If I prescribe an antidepressant, there's going to be risks and side effects that I need to discuss. All right, so let's get into the downer part of methadone and buprenorphine. They're opioids, and so they're going to have typical opioid-like side effects. Constipation is a big one. Trouble peeing, bladder dysfunction is common. Sexual problems is probably number 3, and so those are real. And I'm commonly confronting them and having to treat them. And these, again, are the discussions I have with patients. It's like, look, I'll go the opioid induced hypogonadism route, so the low testosterone route. A lot of men taking Suboxone, buprenorphine have low testosterone due to the medication. And so again, we have that informed consent discussion. We say, look, the literature would say if you stop taking your Suboxone, your risk of dying and overdose goes up. So do you want to stay on this medication or stop it? And they're like, no, I want to keep taking it. So then we have to treat through that problem. So can we reduce their Suboxone dose? Do we need to give them testosterone replacement therapy to fix that problem? And so, yeah, absolutely. Another side effect, having to see me, cost. And so there's treatment obligations. They got to see me. They got to run to their pharmacy. They have to pay money for healthcare. And so, absolutely, there's risks and benefits to every medical intervention. Those are some of the big ones.
Great, thank you. There's one in the Q&A here I wanted to get to. Um, Thoughts on tapers when patient is stable and seems ready to go, or do you ever taper? How fast or slow? How big of a psychological effect does it have when someone is on 2 milligrams of methadone?
Yeah, it's up to the patient again. And so this is true of every medication. You should be reviewing the benefits and harms of medications at regular intervals. And so, you should have that discussion. Does methadone or buprenorphine still make sense for you? Are you getting the benefits you want at an acceptable cost? And by cost, I mean money, but side effects as well. Some patients say, you know what, I'm not sure. I'm not sure that I want to continue taking this. Again, as long as they've been adequately consented, they can make that decision. Patients can discontinue any medication at any time, including methadone and buprenorphine. Tapering can be rough. It's actually fairly easy on the front end. It's surprisingly easy. When patients kind of get a false sense of security, you can take somebody on 120 of methadone and cut it in half, and they're going to be fine, believe it or not. There's not going to be much of a consequence to that. So most patients during a methadone taper, they do fine until you get somewhere in the 20 to 40 milligram per day range, and then it's rough sledding until you get them off. Buprenorphine is the same deal. You can taper them down to somewhere in the 2 to 6 milligram range, and then it's rough sledding below that. It's the last few milligrams that are difficult. So in terms of rate of taper, it's really up to what the patient wants to do. For Suboxone, I sort of suggest a 2 milligram reduction every 2 weeks, no faster than that, and then much slower at the very end. But again, this presumes that they've made an informed decision. I don't do many of these tapers. I seldom do them. Most patients don't want to do them once they sort of know the consequences. It's like other chronic diseases. If you have like Crohn's disease and you're taking biologic medication to control it, you're going to do bad. You're going to do poorly off that medication. Most patients wouldn't make that decision.
Thank you, David. We have 2 more questions here. The first of which is, Hannah says, insurance companies may only approve covering a certain amount, if any, number of treatments. What solutions or treatments do you recommend? And another question, based on what you've said, I'm hearing that opioid addiction is not ever curable and that someone should stay on after treatment ends.
I'll take the first one in terms of coverage. Honestly, the coverage is really good for Suboxone. It was a real hassle when it first was approved in 2002. Lots of prior authorizations. The cost effectiveness literature is pretty clear. I have an entire 1-hour PowerPoint on how cost effective these medications are. So most insurance companies, they pay for it. Now there may be what are called quantity limits, and the quantity limits I don't disagree with. I just want to make sure you're not prescribing crazy quantities of Suboxone, inappropriate quantities. But every health plan, including the Minnesota Medicaid programs, cover Suboxone. Methadone's an odd animal. It's typically paid for privately or through county funding streams, Rule 25 funding streams. It's usually out of the orbit of insurance. I wish it wasn't that way. I wish that methadone was paid for by insurance directly rather than relying on private pay and funny funding streams. There are no cures for chronic illnesses. That's just sort of the bummer. And so there's a lot of chronic illnesses in this world. The issue we've had, I think, with addiction, especially in Minnesota, is that we haven't conceptualized it like it's a chronic illness. Or we may say it's a chronic illness, but we're not willing to treat it like a chronic illness. So no, regrettably, there's no cure for diabetes. There's no cure for ulcerative colitis or Crohn's. There's no cure for psoriasis, heart failure, you name it. This is, opioid addiction is just another chronic illness. But I will say, people with this illness do well on medications. I think if you had to pick a chronic illness, believe it or not, this is a pretty good chronic illness in terms of the treatment options available and how well people do.
Thank you. Two more questions, sorry. Laura asked,
I got time. I'm in no hurry to drop.
thank you, thank you. Laura asked, what are your thoughts on juveniles with opiate addiction and using Suboxone?
Love that question. Difficult question. So there have been a few studies on the use of buprenorphine in adolescents, and adolescents appear to do better on buprenorphine compared to no buprenorphine. It is approved for adolescent use. The FDA approved age on that is 16. I'm aggressive, honestly, with the use of buprenorphine in adolescents, and I'll tell you why. So I just turned 50 a couple weeks ago. If I lost the next 2 years of my life, it would be a bummer. However, I've graduated from high school, I've graduated from college. A lot of the really important developmental things have happened for me. If you take a 16-year-old and they lose the next 2 years of their life, it's a disaster. And I'm speaking as a father. I have 3 sons. One actually turns 17 tomorrow. If they lost 2 years of their life, total disaster. Probably not going to graduate from high school. They might not start college with their peers. And so really the discussions I have with parents is, here's the deal. I think I can back burner this problem with Suboxone. I think we can really arrest this issue and get them through some really important developmental stuff. And if they decline that, I think that's okay. But I really don't like subjecting adolescents to abstinence-based treatments, knowing that they don't tend to work, because it really disrupts important developmental stuff: school attendance, being with their peer group, participating in activities, graduating from high school, going to college on time, stuff like that. So I tend to offer it, and that's my thought process in offering it.
Thank you for your question, Laura, and thank you, David. Final question, Kelly asks, how can family members and allies best support recovery?
I'm going to narrow the question to medications like methadone and buprenorphine, because I do get this question a lot from my patients. Patients usually stabilize really quickly on these medications and their life turns around. But then they come back to clinic and they say, well, my wife wants to know when I'm going to come off this stuff. When are you going to get me off my Suboxone? Or I'm getting static from my boyfriend about the fact that I'm still on this stuff. So I would like to see family members and their allies understand that this is a chronic illness. People do well when they take disease-modifying therapy for their chronic illness. They do decidedly poorly when they stop taking medications for their chronic illness. That's the sort of discussion I'd like to see more of. I'd like to have it reframed around that.
Okay, and one more just snuck in here. Amy asks, with adolescents, is there more risk of overdose while on Suboxone if they relapse?
Probably not. So when you look at how methadone and buprenorphine work, a big part of why they work is they cover the receptors. It's called receptor blockade. So when somebody is taking buprenorphine in a therapeutic dose, most of their opioid receptors are probably blocked or covered with the medication. So if they use heroin, there's really no additional effect. Heroin is not strong enough to bump Suboxone off the opioid receptors. So really it's protective. So in most of my patients, honestly, I tell them that on the front end. I'm like, look, if you use an opioid, it's unlikely to do anything. And they'll come back and they'll sort of sheepishly admit a few weeks later, doc, I tried and you're right, nothing happened. And I kind of laugh and I'm like, well, doctors can't lie. That's part of our ethos. So really, if they're actually taking their medication, it's protective. Even if they try to use on top of it, there's probably no receptors available, so therefore the risk of overdose is low.
Thank you, David. And that is our time for today. On behalf of the Center for Practice Transformation, we'd like to thank you all for joining us, and we'd like to extend an extra special thanks to Dr. David Frenz for once again sharing his time and talents and vast knowledge with us.
Hey, thanks, Joe. Anytime.
Thank you, everyone. Have a safe and great weekend, and hopefully we'll see you next month.